Is TRT the same in the USA as in the UK? Find out more after this.
Hi, welcome to Balance My Hormones video. We're here with Pete, who's got his own YouTube channel, his own sort of social media following. It's in TRT, men's health, sort of providing helpful information amongst, a lot of information or misinformation that's out there. So, hi Pete, thanks for coming on.
Hi Pete.
Hi Mike, hi Sam, how are you guys doing?
Yeah, good, thank you. So we'll just do a general introduction. So did you want to just say a bit about yourself and sort of what you do and how you got into this sort of TRT area?
Yeah, so my YouTube channel is Test Your Levels, and I got into TRT. I run a few businesses, and I just started feeling the common symptoms of TRT, being tired, not a lot of motivation, all that good stuff. And
Yep.
I just got a test from my doctor and came back at 288. He told me that unless I had ED problems, I was losing muscle, and can't remember the last one, but that he wouldn't even talk about the cream. So I was like, all right, this guy really doesn't deal with this. He's older, he's retiring soon. So I went and did a lot of research, and I found a good doctor and started on TRT. And I just found that there's so many factors to TRT, and that there's a lot of bro science, there's a lot of misinformation. And so I just thought I would make a channel, and I would just outline, do some research on the subject, put together, kind of a comprehensive guide of what I found in the studies, and give my opinion and let people make their own decision from there. I don't really think that anything in TRT or healthcare is black and white, and I don't really like to push my ideas on other people. I just try to present information and let people take from that what they do.
Yeah, and it seems like it's pretty helpful because you've got quite a few people following your videos and things. So
we're getting there. It's building. It's a niche topic. And I actually found out you guys because I joined the TRT in the UK and Europe page. And I started speaking with Mike, and we were like, hey, let's do a video. Let's just cover some topics, some of the differences between in the UK and America. I find it very fascinating that the exact same thing can be treated in lots of different ways in different countries. It's really, it's an interesting topic.
Absolutely. I mean, when I moved from the United States to the UK, I wanted to bring an American style TRT to the UK, which was very much missing. So I started this 4 years ago to make a lot of people have options for the TRT, which they weren't getting from the NHS. I know we talked about the VA being something comparable in the US. So it's really good to talk with you and your experiences and work together, because that's what we're trying to do, is just make some friends in the on both sides of the Atlantic with the TRT community.
Yeah.
So I mean, we have the NHS, obviously the National Health Service, and it's very unique. I mean, there's a lot of health services around the world, but ours is sort of, it's been dominating sort of factor in healthcare in total. So stepping out of that system we pay taxes for, sometimes it's hard to find things that maybe they wouldn't want to offer and that you may need. So that's sort of how we have sort of access this area and help sort of provide this service to access to doctors and this sort of treatment. But in the US, what's it like in comparison? I mean, we obviously come across a lot of doctors. We know quite a few in the US, and it seems to be a mixed bag of things, right? I mean, the VA and things for veterans, right? They do provide something, but what have you got over there?
Well, as far as the VA goes, the VA is for veterans, and it's very similar, I think, to the NHS, to where basically, I mean, you go to them and, I mean, almost everything's covered, but they really dictate what you can get and what you don't get. And I actually pulled up, in the VA, there's about 9 million active patients, and 85,000 are on TRT, so that's a little bit less than 1%. And I actually found, this was purely from Reddit. The guy said, I was a Marine infantry, fought in Iraq and Afghanistan. All I can count on the VA is for blood work and x-rays, nothing, and I mean nothing else. I've been blown up a bunch, and my blood work has been repeatedly shown my testosterone levels lower than 200. And I'll just jump. My doctor isn't concerned and won't even talk about correcting my hormone levels. He also refuses to refer me to a urologist or an endocrinologist. I'm not even sure what the point of my checkups are. He suggested I go to a mental health facility for psychotropics instead.
Wow.
So
Yeah.
that was just one random story of, you know, and I'm assuming, I mean, is the NHS similar to that where?
Yeah, I've heard stories nearly similar, identical to the one that you just mentioned about the NHS putting people on SSRIs and other medications for depression, but not TRT, when that could actually be the cause of the problem. And they're always quick to fob you off, say, oh, it's in your head, it's not really low enough, and they're very strict with the target. So it sounds very similar.
Yeah, I mean, I used to work within the NHS, and I think it's great. I mean, for what it can offer, and it covers a lot of things. But then when you need potentially something outside of their scope of practice, it's like it doesn't exist for a lot. The attitude can be very much like that doctor in that example you gave, where, you know, the majority of doctors, well, nearly all of them aren't trained in hormones, and even the in depth of what they do, let alone treatment. Even endocrinologists, because it's it's obviously a funded service, which sounds very similar to the VA. They have cost restrictions. You know, you may end up seeing an endocrinologist thinking that you've got, you know, the person who specializes in hormones, but the majority of their care is things like diabetes, is things, you know, more acute sort of medicine that presents itself within the service. So, you know, somebody preventative, you might call it, or, I mean, the mental health provision itself has been cut massively in the NHS over the years. So, you know, let alone changing practice for sort of hormones. I mean, women's HRT, you know, non-bioidentical sort of, you know, patches and things like that. They've been around in the NHS for a long period of time, but the way that it's used for women is quite antiquated as well. So let alone trying to introduce, you know, hormones as a potential reason why you might have mental health issues, or where I've worked in trauma before, even things like osteoporosis in the elderly and all those sorts of things. So I think sometimes within those organizations, it's quite difficult to change practice that is it takes a long time to get change within it, you know. So maybe that's similar in that sort of organization in the US, if it's funded, obviously, by a certain entity.
You know, I saw something, I can't remember the exact number, but they did a poll of endocrinologists in the United States about fertility, and 25% of them said that they would prescribe outside testosterone for fertility. So that was kind of scary to me. I was like, wow, that's pretty, I mean, these are doctors, these are endocrinologists, but they're not taught hormones in college. There was a video that I watched, it's called Growing Young. There's a doctor on there, if you've probably seen him, he's really jacked and he's ripped, but a lot of these doctors said, we're taught medicines, but we're not really taught hormones. And I'm hoping that's changing now, but I still think you have a lot of doctors that are part of that old school, you know.
Yeah.
I think it's even more so for endocrinologists. I mean, I often say, and I think I put it on my YouTube or my Facebook page, that, you know, endocrinologists should have that title taken away from them, and they should call them average diabetes specialists, because, you know, most of their practice is concerned with diabetes, but when it comes to other hormones, sex hormones and the like, they just don't want to know. They don't understand it, and if they do, they've got very old ways of practicing, which actually, in my opinion, puts patients in harm's way. And I've always found that seeing an endocrinologist is somewhat dangerous. I'm willing to say that, because, you know, I was treated by one, and I've seen them tell patients, oh, just come off of everything. So they go from being treated to having no treatment at all for many, many weeks or months at a time, whilst they just trace the pathway back to find out what's going on, when the patient clearly told them what was going on. They may have come from another doctor that was put on treatment, but they're told to stop doing it.
I mean, the number of guys that have got, so to get to an endocrinologist in the NHS, it's quite difficult as well. You have to be super low below what they call the laboratory range, which obviously we know isn't representative of where you get symptoms, but you know, you have to get through the gatekeeper, which is the GP, who again isn't trained in it, so you just have to meet certain criteria to get through, and then you get to an endocrinologist. And actually, the guys who've like self-educated themselves as patients actually can end up knowing more, you know, questioning about LH and FSH and SHBG and its roles, and estrogen, you know, and endocrinologists saying that estrogen is a female hormone that men don't need. You know, I've heard that before, which is like, so they get there, and then because their attitude is challenged, you know, it often is met with a bit of abrupt sort of a wall. So that can take years to get to. So, I mean, I got to a GP with low levels, and they said because I had facial hair, I was fine. There wasn't a blood test.
Yeah.
You know,
I definitely don't have that problem, but that's
but obviously it's not. But I had a blood test as well, so I had a low blood test. Yes, but apparently that overrode the fact that I had some facial hair. So I suppose that's the NHS in the UK. But
so where did you get your treatment then in the end? I mean, you went to a private doctor?
I originally, be honest, I self-medicated for a little bit. And then I went to a clinic in the US, obviously. I'm not going to mention their name, but I went to a clinic. And then my buddy actually had just a regular doctor that was really knowledgeable in TRT, and I got prescribed through him. Then he converted to what's called a concierge doctor. In the US, it's basically doctors that do not take insurance, but you pay them a monthly fee. So I pay them a monthly fee. I can call him, text him. If I get a cold, I can say, hey, I need some antibiotics. And he's also very knowledgeable in TRT. And so he just kept prescribing me the same stuff that I had. We do blood tests, go over my blood work. And that's kind of where I'm at now.
Is that quite a lucky find in the US to find someone like that, is it?
It is. I mean, there's lots of clinics in the US. There are good doctors in the US. And, you know, our medical system is pretty messed up insurance-wise. And that's why a lot of these doctors are jumping over. They don't want to have 3 people in their office just hitting up the insurance company trying to get paid and fighting with them. So they just say, well, hey, you pay me a monthly fee. I don't take insurance, and we'll treat you.
Yeah.
But yeah, it is a lucky find. A lot of these concierge doctors are $200 a month. But mine, it was a lucky find. I'll leave it at that.
Yeah. I suppose you're talking about like the influence. Maybe there's a big pharma influence in, you know, everywhere as well in terms of changing things in the NHS. There's got to be an influence from the drugs companies, but I suppose that must be insurance-wise. Does that link in with trying to push things like the psychotropic medications or those sorts of things as first-line treatment for anxiety or depression or fatigue? Or, I mean, I've literally heard of guys who have low libido and are given SSRIs because apparently that will help, and like absolutely destroying libido after that, absolutely zero. You know, I just wonder where that comes from, where the guidelines are that they like to follow. You know, the guidelines that say antidepressant medications help with sex drive. I don't know, but
it's in the pharmaceutical industry in the United States, and I'm sure all over the world, they have tons of money that they throw at politicians. That's just the way it is. My wife is in the medical field, and they have a rep for different companies and different drug manufacturers there every day.
Right.
Hey, what do you want for lunch? Hey, we're having this dinner at Ruth Chris to go over, you know, Zoloft or whatever, Paxil.
Yeah.
And unfortunately, there's no testosterone cypionate reps or Sustanon reps that come with Panera and all that. It's not there. You know, they don't make money.
No money for them.
It's not that expensive. And it's a weird world. It's a weird world.
Is there another big sort of provider of healthcare in the US? I suppose you've obviously got your cash pay, and then you've got
Medicare. Medicaid.
Yeah, okay.
Medicaid.
And then there's no chance of getting anything on that. I mean, hormone therapy.
I don't think he's old enough for Medicare. Medicare's for seniors.
Is that right?
For those who are pensioners.
I think Medicaid. I'm not 100%, but I believe Medicaid's kind of the same thing as when you retire. But also, if you have a lower income, I believe you can get healthcare through Medicaid.
Yeah, the Medicaid
is lots of doctors don't want to take Medicaid because they don't like dealing with insurance companies, but they also don't like trying to get paid from the government. So a lot of people on Medicaid see doctors that maybe aren't as good or are more of a volume type practice.
Yeah.
Where the more patients they see, the more money they make. It's a weird system. It's really weird.
My little knowledge from the States, I also studied the US healthcare system. Medicare is a federal program for the senior citizens, the pensioners. Medicaid was administered by the states, and they got like a block grant, I believe, from the federal government to administer to the states. And so that was for the low income, like you said, Pete, for the Medicaid. So I'm not sure what's covered.
Makes sense.
Yeah.
Fair enough.
But every state's different, I think, how they administer it.
Yeah. Okay, cool. So, I mean, you know, I think we're going to go over sort of what do you do for your TRT protocol? Is that something you're happy to go over?
Yeah, I do. I take testosterone cypionate. That's pretty much the most common here in the States.
Mm-hmm.
I do 200 milligrams a week, split into 2 injections. I take, right now I'm taking 250 milligram IUs of HCG twice a week. I cut that down a little bit. I didn't feel like I needed the full 1,000 per month or per week. And the less medicine, the better, if you can. And then I take 1 milligram of Arimidex twice a week. And I do sub-Q. I do it with 27 gauge insulin needles. I switch between belly fat and butt fat.
Mm-hmm.
And I feel really dialed in. I feel really good.
That's cool.
I've lost, since I started TRT, I've lost 35 pounds. I've definitely gained a lot of muscle. I don't know how much in weight, but definitely been a game changer for me.
That's a good amount of weight to lose. Yeah. I mean, you don't have Sustanon in the US. I know you don't have the Sustanon, but interestingly, I take Sustanon every week. You know, 125 milligrams a week with HCG as well, 250 IUs twice a week, and I have tried. You know, I think it's quite interesting that, you know, I think it's really important to note that a lot of guys, you know, particularly what we see, you can try daily, because I've tried daily, you know, injections and going up in dose and every other day and all the way up through, and I still feel the best, you know, or no different, you know, with my dosage every week. And I think that's important that, you know, I've noticed that it's quite personal in that aspect. Obviously, those like daily dosing and things like that, I think is really good to be made aware of as an option, like the creams, like the scrotal cream and things. But equally, like, you know, guys that only feel good on doing a dosage of testosterone a week. You know?
I mean, there's not one way to do TRT. That's why we say bespoke HRT, bespoke TRT. Our doctors will try various different combinations that suits the patient, and I think they look at a combination of SHBG levels and just kind of how the patient feels. I mean, usually the lower the SHBG level is normally an indication for more frequent dosing and or creams. So my personal protocol is, it's been all over the place. I mean, when I was treated in America, I had anything from cypionate once per week, once every 5 days, once every 4 days, different doses. The latest in the UK was Sustanon, 125 milligrams, which is half the ampule, every 7 days, every 6 days, every 5 days, and now it's I'm doing about 0.3 milliliters, so that would be around 76 milligrams of Sustanon every 3rd day. Yes, and it seems to work just fine. And then HCG 250 IU.
It's interesting though, like you talk about Sustanon not being available, you know, in the US, but we do know doctors that like to mix testosterone propionate with you know, testosterone cypionate, obviously, because you have your you know, have your compounding pharmacies over there.
Yep.
So yeah, so I mean, again, and apparently some guys can feel better on that. And I think that's what it's about, is that you obviously just got to find out what works for you, right? There's so many variables, you know, interperson variability, and yeah, I think that's just a key part of therapy.
Yeah,
you know,
there's so many different factors in TRT, and everyone reacts differently to different things. So that's why, if there was just a single protocol that worked for everyone, then we wouldn't be making this video, because everyone would just take however much, however often, and they would be good. And that's just not the way medicine works. And medicine's on a case-by-case basis, and that's why I have an issue with people that just say there's only one way to do something. You know, most things in life are not black and white. Most things are somewhere in the gray area, and I think TRT definitely falls into that. So,
yeah. I mean, do you think people who are saying there's just one way to do something, there's a sense of insecurity, or they might be trying to sell something that's proprietary to them, or?
I don't know. That's a tough one. I mean, I don't know if maybe someone had a particularly bad experience, you know, taking maybe, you know, something, and then, you know, they feel like that was the reason, and then they just kind of tell people that not to do that because they had a bad experience. But I don't know. I don't know.
Yeah. I mean, in America, I got the sense, and tell me if I'm wrong, that there was some sort of providers and stuff that weren't really monitoring patients properly and just sort of shelling out, you call them refills, right? Like over and over and over.
Sure.
Repeat, you know, for the year, and not really getting monitoring and things like that. And there was a bit of a surge of anyone who could prescribe just trying to cash in on just getting repeats and not having blood work, not speaking to the doctor, things like that. And I just wonder whether in America, and I may be wrong, but it's sort of a sense I get from the American doctors when we meet them is that maybe they're just trying to fight against that and trying to bring it back to sort of normality, you know, of better care, and probably saying, well, this is what needs to happen. You should be doing this, and this is how it needs to be done. Maybe to fight against that. I don't know, you know.
Interesting. I had not heard of that, but it's just interesting, you know, people take such a hard stance on something that's medicine, you know, like you can't say, okay, well, you've got cancer, so we're going to give you this and that's going to work. Like medicine just doesn't work like that. That's why every medicine ad you guys don't see medicine ads because
have those.
I've seen them in America.
America and New Zealand are the only countries that for some reason decided that was a great idea. But at the end of every one of those, you hear a long list of side effects, and
it always ends in death.
Bad.
Yeah, it always ends in death. Like as a side effects.
Permanent blindness, you know, anyway. But you know, so everyone reacts differently to that medicine. So 98% of people had no side effects and it worked. There's still that 2% that had crazy issues or it didn't help them. So.
But you know, like the daily thing, like obviously daily works for a lot of people. But I've done daily. I've done no HCG. I've worked up and increased my dose and I didn't feel better. You know, so I was just doing daily injections. I felt good. That's what I'm saying. I didn't feel better. I still felt okay. Maybe I was trying to chase something more, but you know, I just felt just as good doing a weekly thing. And with HCG, you know, not a massive difference with that. Whereas it can make some people feel pants, you know, feel awful. So it's definitely. I mean, I suppose I'm an example of where it's happened, but we see it all the time. You know, just one person with the same blood results at a certain point just feel completely different to another person on the same protocol doing something like that, you know?
Yep, I agree 100%.
That's cool. Okay, thanks Pete for coming on and joining us. I know we'll do a few other videos. It's just about sharing some information with guys and trying to be helpful. So thanks again. Obviously you can check out Pete's YouTube channel.
YouTube channel is Test Your Levels. I want to thank you guys for talking to me as well. I do this every day, whereas I just do research and make kind of somewhat funny videos here and there. But it's really interesting hearing all your you know, insights and knowledge. So that's really cool. I appreciate the time you've taken out of your day.
No worries.
Thanks for good.
So yeah, our YouTube channel, just Balance My Hormones YouTube channel, if you want to check that out. But
EU, TRT UK.
Yeah.
And we'll also put a link to Pete's channel in this video. So you know, subscribe to both our channels. If you like the video, please like it, and if you don't like it, you can hit dislike.
Yeah,
but we'll be at like.
Yeah, and subscribe. Yeah.
Don't forget, check out the description. Click on the subscribe button, go over our channels, get your levels tested, and I'm glad that making friends in the TRT community. I think we all need to stick together.
I agree.
It's a very serious thing, you know, and I think it's starting to come to light, and I hope it becomes more mainstream, and that stigma of, you know, scary testosterone slowly goes away over time.
I think it'll happen if we all work together, all of us in the field, you know, rather than fighting each other, that we all come to consensus that all we're trying to do is help men and women have access to these hormones when they've been denied before.
I think with all the birth control and SSRIs floating around in the water, I think there's going to be plenty of TRT patients for everyone.
Yeah, I think so.
Exactly.
All right, well, thanks. Yeah, thanks very much.
Yeah. Thank you guys. Have a good one.
All right, see ya.